And welcome to the topic Benign Acanthoma in the Dermatology module. By the end of this topic, you should be able to define benign acanthoma, explain the pathophysiology of the disease, outline the causes and classification, describe the clinical manifestations of benign acanthoma, outline the investigations done for benign acanthoma, discuss the principles of management, and discuss the complications and prognosis. Let's get started. Benign acanthoma includes keratoacanthoma, seborrheic keratosis, and lichen planus. Keratoacanthoma is a low-grade tumor which originates in the pilosebaceous glands and resembles squamous cell carcinoma. Kerato means cornea or horn, while acanthoma means neoplasm or prickle cell layer of the skin. Seborrheic keratosis is the benign skin tumor that originates from the cells of the epidermis. Keratinocytes are the part of the epidermis that produces keratin, and the suffix -osis means abnormal. Lichen planus is an inflammatory disorder of the skin or mucous membranes with no known cause. Lichen originates from Greek lichen, which stands for tree moss, lichen on the skin, or lichen-like eruption on the skin. Skin is made up of two layers, the epidermis and the dermis. Epidermis consists of stratified squamous epithelium, which are the keratinocytes in progressive stages of differentiation. Layers of epidermis are the stratum corneum, the absorptive layer, stratum lucidum, which is only found in thick skin, stratum granulosum, also known as the granular layer, stratum spinosum, the prickle cell layer, and the germinative layer known as stratum basilae. Epidermis functions as a physical and biological barrier to prevent penetration by irritants and allergens. Dermis in the inner layer of the skin and is much more thicker than epidermis. Its function is to protect and cushion the deeper structure from mechanical injury, providing nourishment to the epidermis and for wound healing. Overall, the skin is essential for protection as it forms a protective barrier to protect us from mechanical, thermal, and other physical injuries, as well as harmful agents, excessive loss of moisture and protein, and harmful effects of UV radiation. Skin is also needed for thermoregulation, altering blood flow through the cutaneous vascular bed. Lastly, the skin is the organ that provides sensation to the body. Keratoacanthoma is caused by UV, trauma, human papillomavirus, genetic factors, immune status, basal cell carcinoma, and the mutation of BRAF inhibitors. These abnormalities lead to hyperkeratosis of the infundibulum. There are three stages of keratoacanthoma, known as proliferative phase, which lasts for 6 to 8 weeks, the maturation phase, where keratoacanthoma maintains its crustiform appearance, and involution phase, where keratoacanthoma regrets into atrophic scars. Seborrheic keratosis is due to mutation of fibroblast growth factor receptors and as well as the PIK3CA oncogenes. It leads to benign clinical expansion of epidermal keratinocytes. Lastly, lichen planus. This condition is associated with a virus, drug, and contact allergen which causes alteration of epidermal cell antigen and activation of cytotoxic CD8 T cells. These altered self-antigen cross-react with normal self-antigens found on basal keratinocytes, leading to T cell targeting and apoptosis. So here, keratoacanthoma. This slide shows the causes of these lesions. Keratoacanthoma is caused by UV radiation, and it may be from the sun or tanning bed. HPV infections, genetic mutations of P53 and TPI2 gene, long-term exposure to cancer causing chemicals such as tar in cigarettes. Seborrheic keratosis may be inherited as autosomal dominant inheritance or as a result of UV radiation. And lichen planus is associated with hepatitis C and contact allergies such as mercury, copper, and drugs including antimalarials, ACE inhibitors, thiazide diuretics, and NSAIDs. Keratoacanthoma is classified into giant keratoacanthoma, keratoacanthoma centrifugum marginatum, which has multiple tumors growing a localized area, multiple keratoacanthomas, solitary keratoacanthomas, which is benign, rapidly growing and locally aggressive tumors which occur in the nail apparatus, and generalized eruptive keratoacanthoma, which consists of hundreds of thousands of tiny follicular keratotic papules. Seborrheic keratosis classification is based on its histopathological morphology, and lichen planus can be classified into reticular, papular, plaque-like, erythematous or atrophic, ulcerative, and bullous. Patients with keratoacanthoma will complain of appearance of dome-shaped nodules at sun-exposed hair-bearing areas such as the face, head, neck, and dorsum of extremities. Pain, pruritus, erythema, and bleeding are common complaints of seborrheic keratosis which can occur anywhere on the body. The lesions are benign and slow-growing lesions. While lichen planus has lesions that are polygon-shaped, itchy, and violaceous as well as flat-topped papules, it commonly appears on flexor wrist, dorsum of the hands, lower back, ankles, and the shins. Examination of keratoacanthoma lesions reveals small, round, pink or skin-colored papules that grow rapidly. It is commonly dome-shaped with a central keratin plug that result in a critiform appearance. Seborrheic keratosis has dull, wavy, and verrucous surface that results in a stuck-on appearance. Its color ranges from light to dark brown, yellow, and gray. It can be isolated lesions, but there may be tens or hundreds of them. Lichen planus has 6 P's which are purple, polygonal, planar, pruritic, papules, and plugs. It has shiny serge and fine white lines which is known as Wickham striae. It is firm on palpation, scattered widely, grouped in plugs, or arranged in annular, linear, or actinic patterns. Diagnosis of keratoacanthoma requires excisional or deep incisional biopsy. It is done to differentiate it from squamous cell carcinoma. Histology of keratoacanthoma shows singularly well-differentiated squamous epithelium that show only a mild degree of pleomorphism. Seborrheic keratosis can be investigated using dermatoscope, which will show miliary cyst, comedo-like openings like with fissures, and ridges, while skin biopsy is done if there's ulceration, rapid change in size, or for the large lesions. Dermatoscopy of lichen planus show Wickham striae, while biopsy of the lesion reveals sawtooth appearance of epidermal hyperplasia, hyperparakeratosis with thickening of the granular cell layer, and vacuolar alteration of the basal cell layer of the epidermis. Other investigations include radiographic imaging to look for presence of osteolysis if there is subungual keratoacanthoma. Medical therapy is used for both symptomatic and definitive treatment. Topical 5% imiquimod cream, topical 5% 5-fluorouracil cream, and intralesional methotrexate injections are indicated for keratoacanthoma. Seborrheic keratosis can be managed with ammonium lactate and alpha-hydroxy acids to reduce the height of seborrheic keratosis. For lichen planus, if it is immune-related, high-potency topical corticosteroid can be prescribed. Oral antihistamines such as hydroxyzine is used to control pruritus, while hypertrophic lesions are treated with intralesional triamcinolone acetonide. Surgical management is indicated for cosmetic reasons and to reduce risk of recurrence. Keratoacanthoma, if less than 2 cm on the extremities, electrodesiccation and curettage are indicated. For lesions more than 2 cm, most micrographic surgery is done. Seborrheic keratosis is managed by cryotherapy, which uses liquid nitrogen or carbon dioxide to rapidly freeze the targeted cells and result in cell death. Shave excision is reserved for skin conditions in the epidermis without the involvement of dermis. Acute complications of seborrheic keratosis is pain and discomfort. Chronic lichen planus can cause residual hyperpigmentation. Keratoacanthoma has an excellent prognosis following surgical excision. As seborrheic keratosis is a benign lesion, it has a good prognosis too. Lichen planus often regresses within 18 months. Let's summarize what we have covered so far. Acanthoma is a skin neoplasm composed of squamous or epidermal cells. It consists of keratoacanthoma, seborrheic keratosis, and lichen planus. They may be a result of UV radiation, infection, some gene mutations, and contact allergies or drugs. Each subtypes have its own clinical features. Skin biopsy, dermatoscopy, and other imagings are indicated to diagnose such lesions and to assess surrounding structures and organs. Definitive treatment is surgical excision for keratoacanthoma and seborrheic keratosis, while corticosteroids are used for lichen planus. We have come to the end of this topic. Thank you.